We don't know that to the extent that I can make a strong comment. Why? Because the enrollment was limited in the clinical trials to a certain age group, and so we don't have a lot of post-marketing experience where we can then report out, hey, in this group of patients that are a bit older, we don't have that kind of information. What we do know is that the patients coming into this trial had active disease. These were patients that were having attacks, they were having enhancement on their MRI in many cases, and that's a population that we want to target. We know that from the early trials, when we looked at secondary progressive MS, we didn't see an effect like we wanted. And so, although I don't know about an age differential, one might assume that using it in the relapsing population is very important. Every MSologist will tell you their chili recipe, and I'll share that mine's the very best one. There is no easy rubric for how you choose a medication. I can tell you how I approach it. I've changed how I treat MS. And I think historically, we used what I refer to as an escalation model, where you started a patient on a drug that had a very tolerable safety side effect profile, and in hindsight, in populations, maybe mild to moderate efficacy. And if the individual patient responded to that, then we were very happy. And if they had breakthrough disease, then we so-called escalated to something that at least emotionally we thought might be more efficacious, but maybe has a less favorable side effect profile. And on that so-called second-line therapy, if things went well, great. But if they had breakthrough disease, well, then we again escalated. And there's an intrinsic problem to that. Each time we say it didn't work or they didn't respond, we're talking about brain damage that you can't give them back. And so you could almost ask the question, what's an acceptable rate or amount of brain damage that you're allowed to accrue as I treat you? Now, I've been asking my patients that question, and the answer is ubiquitous, none. And so this drug offers an opportunity to not use an escalation model. It uses an opportunity to induce the patient. These are terms that we borrow from other conditions like oncology. And so you categorically can treat the patient in a bit of a different manner. I have started to take that so-called escalation curve and turn it upside down. And I start a conversation with my patients about their goals. What are your goals in 20 years? And then I'd like to ask them what their risk aversion is. And we just have a conversation about those aspects. Then we start to talk about therapies. And I tell them, I'm going to serve up to you the most effective therapy that I can come up with in your situation. And then you have to tell me how comfortable you are taking it. I do it backwards. I feel very good about approaching MS in that manner. I regret, actually, that I allowed patients to have breakthrough disease on what we now refer to as platform therapies or first-line therapies, and I can't get that back for them. Honesty. I tell people what you just told me. I said, I don't have data going out past 5 years. I reassure the patient that there are a large cohort of 1,200 some patients that are in front of them. They're 5 years in front of them. And so in the clinic setting, that's actually reassuring. As we continue to learn from long-term cohorts, they'll continue to be 5 years in front of my patient, in this case. And so we at least can say, if there's a signal 5 years down the road, we're going to see it before you come to that point. But we're just honest and say, you know, we don't have all the answers, and we certainly don't know long-term, and so we're going to learn together. And if that's something that makes a patient uncomfortable, we have to talk about that. Some patients say, look, give me the drug that you've had the longest or has the best safety profile. And it's important to listen to a patient when they tell you that. But a lot of patients I have found are very willing to embark on this journey with me, with the understanding that we don't have all the answers just yet. The answers that we have collected are profound. It goes in a couple different directions. Roughly 33%, if you will, of patients don't have the response we're looking for with alemtuzumab. It would be outstanding if we could identify those patients a priori so that we can consider something else. And so there's an area of research. Looking at, as you brought up, subtypes of patients, older patients, younger patients, purple patients, green patients, and trying to better understand Those is another area of research. What we've been discussing today largely is the long-term follow-up. And to speak to your point, you die with MS, not from it. And so you're going to have it your whole adult life. And so understanding what happens 5 years, next year we'll hear 6 years, the year after that 7 years, that's research that's very, very important.